May I welcome you to a Partnership Centre in Health Systems Sustainability webinar on the impact of COVID-19 on the Australian health workforce. I'm Jeffrey Braithwaite and I'm going to facilitate the session, and I'm joined by Liam Caffery and Tony Scott, who I'll introduce shortly. So just a little bit about the webinar itself. Firstly though, let's do an acknowledgement to country. We'd like to acknowledge the traditional custodians of the land on which this university is situated and wherever you might be. Where we are, the Watamatagal people of the Darug Nation are the people who inhabited this land. These are people whose cultures and customs have nurtured and continue to nurture this land since the dream time. We'd like to pay our respects to the Darug people, and we also wish to acknowledge the elders of the Darug Nation, past and present and emerging, and pay our respects to them. We'd like to also pay our respects to those from other Aboriginal nations upon the land you might be at the moment. So a word about the Partnership Centre for Health Systems Sustainability. This is a large footprint of research right across the country. So the Partnership Centre is really a flagship research piece of infrastructure, research infrastructure, with many, many people across the whole country and internationally interested in its work and contributing to it. We essentially break our work up into three research streams. One is on analytics, technology, and shared data, the big data proposition underpinning a sustainable health system. The second area is reducing waste and low value care. We'd like to promote more high value care, and one way is to look at how we can minimise waste and minimise the amount of low value care that might be produced. The third one is an economics one, although to be frank, there's economics and financing across the other two as well, and there's lots of crossovers with these three lots of research, and that is to create better value for the health dollar. In fact, we say, can we create better value for every health dollar that's deployed to support patients and their care? We have a lot of system lead and system-based investigators, that is people who are actually in the system as investigators with us, and people who are more researchers who are leading a piece of research. And we're going to hear from a couple of them today. We also are underpinned by what we used to call our central coordinating unit, but really has morphed into an observatory on health system sustainability, trying to capture the benefit not just of our research, but research right across the country and right across some international groups who are trying to underpin their health system with sustainable practices and knowledge. So that's a footprint, a map, a mud map of all the various people who are involved. To be frank, there's more than this, because those folks who we list and those organisations and entities all belong to a lot of other organisations and entities. And if truth be known, there's no end to the number of people who are involved in this Partnership Centre of ours. We're very proud of the work we do in the core, in the research, in the 9 research streams that we fund, but we're also very proud of all the relationships we have with various people across the country, all of whom are interested in what we're interested in. How do we create a health system that's built to last for the future? And in this year of the pandemic, that has become increasingly obvious that it was wise for NHMRC and the funding partners to create this research grant in the first place. A couple of studies, new research that we've been doing to look at this notion that we need a sustainable health system, and especially since COVID-19 has come upon us. Here's a project that we've been working on with 40 health systems. We call it the 40HSC19 study. And it's been looking at how all health systems have been affected by the pandemic, which of course we all know, but they have been affected differentially. So we looked at 40 health systems and we looked at what was their capacity to respond to the pandemic pre-pandemically, before the pandemic came along. What was the readiness, if you like, the propensity to be able to respond to any pandemic before the pandemic hit us? Then, once the pandemic came on, what was the stringency of their responses? Did they do social distancing? wearing masks, quarantining? Did they do all those sort of things early or later? And we know now if you didn't do this early, then you really saw a ramp up, a major wave of coronavirus cases and deaths. And then thirdly, what was their approach to testing? Did they go narrow and test only specifically vulnerable groups, people in residential aged care facilities, for example, or those who were on the front lines of care? Or did they go broad-based in their testing and offer tests to everyone in the community with the view that if those who have symptoms know that they actually have COVID-19, they'll be more likely to quarantine? And then fourthly, what were the relative effects of all of those three on deaths? So that's all in this paper. If you're interested in reading it, it's on advanced open access. The second one was related, and this was done in conjunction with the International Society for Quality, ISQA, which many of you know about. And that was a survey of 1,100 people across 97 countries. Most respondents were from Italy, Australia, and India, which are three nice comparative countries to look at how people handled coronavirus. And the key findings were pandemic responses differed across countries and WHO regions. And by the end of July, most countries had adopted measures that we know are good at mitigating the effects of the pandemic, but a number of countries had further progress to make, and other countries had done relatively well. And of course, Australia has done relatively well, as we know. There's a couple of papers that are just being published, fresh off the press. The ink is still wet on the papers. And in terms of national health systems, the 40-country study, these are the countries, and these are where they fit into whether they did well relative to other countries, relative to their response to the pandemic. So that's a snapshot of this paper that's on open access and is an advanced publication ahead of it actually coming out of the journal. I won't worry about the details. It's much more important that we hear Tony and Liam speak, but it gives you a snapshot of how we've been working with these 40 countries to understand their pandemic response. And here's the way we've done this study. And this is interesting if you're a researcher interested in method. So we clustered all the studies on three two-dimensional graphs, government capacity to respond and stringency of response, government capacity to respond and broadness or narrowness of testing, and broadness of testing and stringency of pandemic response. And we've created a three-dimensional map of the 40 countries. And so you can see where your country fits in to this three-dimensional picture. And of course, that changes across time. And where mapping changes across time as we see people go first through initial wave and then second and third waves as countries learn or don't learn the lessons of pandemic management. And here's perceptions of reaction time to infection prevention and infection control in healthcare organizations across the 6 WHO regions. And it's differential, even at the level of regions, whole regions, it's differential in terms of how people responded to the pandemic. Very fast, slow, or very slow. So these early results, I guess, are interesting in themselves, and they frame what we're going to hear in much more detail from Liam and Tony. Could we remind, I've just been advised to remind attendees to ask your questions through the Ask Questions facility, and we'll be able to capture those, answer some during this hour, but also get back to you if your question needs us to follow. So that's all from me. While Tony puts up his slides, let me introduce him. So Tony Scott is a member of the PCHSS, the Partnership Centre. He's a very good friend and colleague over many, many years. He's just calling up his slides. He's the Health and Healthcare Program Coordinator at the Melbourne Institute at the University of Melbourne. He's a Fellow of the Academy of Social Sciences in Australia, immediate past President of the Australian Health Economics Society. Tony, that means that you have to herd those cats, all those health economists in the country, does it? Well, you've done a fine job. Some of those are very good friends also of the Partnership Centre. He's also board director of the International Health Economics Association. He established the Medicine in Australia Balancing Employment and Life, the MABEL study, which many people have heard of. And that's a panel survey of 10,000 doctors. And he's research lead investigator on this Partnership Centre. And I'm proud to call him a very good colleague of mine. So Tony, you're going to talk about the impact of COVID-19 on the health workforce. Over to you. A warm welcome and thanks for joining us.
Thank you so much, Jeffrey. I hope everybody can hear me, and it's nice to be here, and thank everybody for turning up. I just want to first of all acknowledge some funding for this from ANZ Health. They're able to provide funding for the MABEL COVID-19 SOS survey that I'll talk about in a moment. And also I'd like to acknowledge just the assistance of Terence Bai in analysing and putting some of these data together. I guess, sorry, my screen isn't advancing. There we go. What I want to do is just broadly speak about the impact of the pandemic on the health workforce and talk about two broad things: how the pandemic has changed demand for healthcare, and also how healthcare has responded in terms of how the organisation has changed. I think I want to ask kind of two questions which we can think about. What will change permanently that's already changed? What's going to stick? And then does that give us any opportunities for effective redesign of the system? Which some of us are hoping for. In terms of changes in demand, I guess this is one of the main issues that the health workforce faces: the people turning up to see them. And I think after COVID, the who's turning up, how often they turn up, and when they turn up has really changed quite a bit. And this is due to people's fear of contracting the virus, so they're not visiting the doctor as much. Fear about overloading hospitals. So people are reluctant to go to hospital and go to health facilities. Change to people's working patterns. More people working at home. Does that mean that they change the GP that they go to, for example, or change other aspects of their healthcare? The key issue, I think, is the fall in income and job loss that's happened because of the recession that's happening right now. And that also influences the affordability of private healthcare, which is an ongoing issue and an important trend that changes how much people use the healthcare system and what parts of the healthcare system they use. There's also evidence of socioeconomic differences in how people use the healthcare system, and those, where the burden of COVID and the effects of COVID on jobs are concentrated amongst more disadvantaged populations. And this has led for people to delay screening and treatment for minor conditions, but also delay treatment for more serious conditions. So I think, we're really not sure what aspects of this are going to stick, what's going to be temporary, and how much is there going to be a bounce back in this kind of demand. So all this has really impacted on what the health workforce does and how the health system as a whole responds. I guess this is some data from taking the pulse of the nation survey that's run by the Melbourne Institute where I work. And this was a weekly survey of 1,200 Australians, representing South Australians since around June. And we managed to squeeze in some health questions. So this is a proportion of people who needed to consult a health professional but chose not to in the past 30 days. We can see that over time, there's been some changes, but mainly one of the big things is it's young males and females who are more likely to not to visit when they think that they need to, and that has changed over time. Whereas some of the older age groups are more likely to visit. So there has been some changes in demand by age and by gender, and that influences the kinds of patients the doctors see and health professionals see. So I think that's an important part. But the fact that older males and females are less likely to kind of avoid healthcare is a good thing, because they're generally the least healthy, and the young people are the most healthy. So what we don't know is whether the avoided healthcare is for very necessary healthcare or something that actually can be avoided. So that gives us some idea into how patterns of demand might have changed. And this is the same kind of data, but by financial stress. So also asks a question of how financially stressed people are. And we see that around 30% of people who have high levels of financial stress are more likely to avoid healthcare. So again, this is a big issue amongst people who have lost their jobs or who are where their jobs are uncertain, and that happens across the spectrum as well. So it's interesting to see how these patterns have changed and how people's financial circumstances also affect their demand for healthcare, which affects the kinds of people that the health workforce treat and see. So that's important. And there's, there's an emerging picture of these things happening, but again, it's not as comprehensive as we would like at the moment. So the health workforce has responded in many different ways, and it's also part of how the health system has responded, because health workforce is a big part of that. The first thing is just a reduction and reorganization of public and private hospital capacity to cope with COVID-19, to cope with the expected increase in hospital admissions. We know that certainly earlier in the pandemic, we know that a lot of elective surgeries were cancelled, non-urgent care was cancelled, and that's, the Australian healthcare system wasn't hit as badly as other healthcare systems, which is good, but nevertheless, these changes happened like overnight almost, and it caused a lot of stress in the system to kind of reorient and reframe the whole way that care was provided. It also meant that in terms of the workforce, there was redeployment of staff, retraining of staff, and re-employment of health professionals who had already retired or doing other jobs. So there was a huge change in what health professionals were doing during that period. And this also, even within institutions and practices and hospitals, led to important workflow changes to minimize infection from and between patients. And that in itself caused reductions in capacity and the ability to treat a lot of people at the same time. But again, these things, as I said, all kind of happened within a matter of weeks, and the system did remarkably well to really reorient itself in such a short time. Now, within that emerged new models of care in hospitals and primary care. And a lot of these new models of care, a lot of us want to see continue, I think. The first is virtual care, which Liam will talk much more about after I finish, but that includes telephone and telehealth, use of digital technologies to monitor people's chronic conditions at home, and also a big push for electronic prescribing. So a lot of these things, are more convenient for patients, they save costs, but also these things happened overnight as well. And they were things which were kind of trickling along for years, but didn't really have much of an uptake. And now it's all going off really. So that's an important part of this new models of care for both patients to interact with health professionals, but also a new way of delivery for health services, which has a lot of implications for how health services and health professionals work. And also as well for healthcare, these changes in demand lead to changes in revenue. Under a fee-for-service system, demand goes down, your revenue goes down straight away. So that's been a big issue. And so there's been a lot of volatility in demand, and so volatility and uncertainty in revenue for lots of private practices, which I'll talk about later. And also, as I've seen in the budget, there's been a huge increase in government expenditures in order to deal with COVID-19 and its implications. But it's important, given that increase in expenditure, work out, well, of that, what's going to be short term, and what of that increased expenditure can we try to sustain to kind of support some of these reforms that we might want to see continuing after COVID. So what I want to do now is just talk broadly about the impact on utilization of healthcare, which is a function of both people demanding healthcare differently and also people supplying healthcare differently. And this shows this the percentage change in Medicare items over time and for different kinds of Medicare items. So again, we're not looking at public hospitals here. This is just the private sector essentially. And we can see that certainly in April 2020, there was a huge dip for most areas of care, for specialist attendances, operations, pathology, diagnostic imaging, less so for GP visits because they were supplemented by telehealth. We can also see a huge bounce back in May and June as well. So although there was initial shutdown, and that was partly to do with the cancellation of elective surgery across most states, there has been a resurgence of demand and utilization, and we're not sure, I guess, whether this bounce back is temporary, how long the system will take to catch up, and therefore after it's caught up, what's the resulting level of utilization? Are we going to go back to what it was, or is it going to be different? And obviously these averages contain a lot of heterogeneity, so although I might say it's settling back to what it was, within that, a lot of things are likely to have changed. So this MABEL short online survey that we conducted in early May this year, based on the MABEL survey, we sent it to all doctors who had previously completed MABEL in previous waves. And we got, it was an email only survey. So by doing that, we're going to get a low response rate, but certainly we had responses from over 2,000 GPs and other specialists. And the data we used were weighted to ensure representativeness of the population. So again, this is a snapshot, and we're able to compare some of the data to their responses before COVID in MABEL Wave 11, which was conducted in May 2018-19. So I'll just summarize some of the key results from that survey. As I said, this survey really, these results focus largely on GPs and other specialists in private practice. We do have similar data for public hospital specialists as well, and that shows very similar patterns. And obviously that there's many of the kinds of health professionals that have been affected that we weren't able to look at. This is the impact on income for GPs and different kinds of specialists. So we can see, first of all, let's look at the highest one. So we see surgeons and anaesthetists, they reported their income to have fallen by over 50% in early May. And that was largely because of the cancellation of elective surgery and other activity. Also of interest is it for GPs. Some GPs are like 10 to 15% on the right-hand side of that first set of bars, experienced an increase in income. So there's been a lot of heterogeneity within. Some GPs have been hit hardest than others in terms of the fall in income. And this basically also asks a question on the falls in the number of patients, and this kind of matches that. Obviously, number of patients equals income in the fee-for-service system, so they match together. But certainly we've found that GPs in urban areas are more likely to report a fall in income. GPs in more affluent areas are more likely to report a fall in income. We think that this is influenced by the mix of bulk billing and private billing before COVID. So we know that GPs in affluent areas are more likely to charge higher prices and not bulk bill, charge richer people more. And so when you have a privately billed consultation substituted by a bulk billed telehealth consultation, there's a drop in revenue there. And so those doctors are probably, well, as we see, have been hit the hardest. And so that's an issue, again, with the fee-for-service system and how that differentially affects different types of doctor depending on how the pattern of demand has changed. We asked about the financial stress of the practice, and we can see that like 10, 30, 35, 40% reported moderate or very financially stressed in that week in early May. Although Non-GP specialists experienced the largest fall in income. They were slightly less financially stressed than GPs, and that's obviously because they start off from a higher base. They earn about a third more than GPs. So again, GPs felt more stressed because of kind of proportionately smaller losses in income, and that's an important thing to consider when thinking how to do that. So again, GPs are more likely to report financial stress if they were urban, if they were smaller or larger practices. Those in the middle were okay. And other specialists were more likely to report financial stress if their practice was larger. So again, it just tells us that there's a lot of different things going on here. This is a question asking what's the likelihood that your practice will be sold or closed in the next 6 months. And these proportions are quite low, 5.6, 8.4% for GPs and non-GP specialists. We could see that for non-GP specialists, it's those in the smaller practices and who are practicing solo are more likely to kind of shut up shop or want to shut up shop. And for GPs, it's those kind of doctors in the 2 to 3 doctor practices who are more likely, who seem to be a bit more vulnerable to that. Obviously, larger practices may be a bit more protected from this. And we can see as well, if we look at this by age, for non-GP specialists, it's the older doctors who might shut up shop. And so these might be people who are already thinking about retirement and maybe just want to close a bit earlier than usual. So this was in May. We don't know what's happened. We don't know whether that has eventuated or not. This also suggests that there could be some consolidation in the market. We know very little about private specialist medical practices. We know that there has been consolidation over time, i.e. bigger practices starting to emerge of larger groups of specialists. We know that they also, once that happens, we also know that they charge higher prices to patients, which isn't good. So it's important to watch that market, even though there's very little data on that particular market. During COVID, doctors did a lot within their practices to cope. As I said, a lot of these changes occurred overnight. We can see that 50% of non-GP specialists had applied for JobKeeper for the practice staff in early May. Many of them reduced hours of staff for some staff, used unpaid leave, laid off staff. So there was a big churn in how the staffing of these practices. Some of them had to really improve practice management. So there was obviously appointment systems had to change. And also, some deferred business loans, took on additional debt and changed things around. So, there were a lot of internal changes to these private practices, and that, obviously, we haven't looked at the internal changes in hospitals as well, which would have been significant at this time. One of the things that we're increasingly worried about is the stress and mental health of our health professionals. We need healthy health professionals to have healthy patients. We know that. We can see that in terms of stress, that around 60% of GPs and non-GP specialists said that they felt stress more often than usual, with about 10% saying that it was a lot more often than usual. Those who had a fall in income were more likely to report increased stress than those with no change in income. So, these again are largely, I would guess, short-term effects that are already started to dissipate, but there remains continuing uncertainty about the system, about COVID and everything, which still means that I'm sure stress levels are higher than normal. This is the impact on mental health. This is a Kessler K6 mental health scores. And here we compare doctors who filled out the MABEL survey before COVID and filled out our COVID survey in 2020. And this mental health score, we can see a score above 19 is a score of probable serious mental illness. And the Kesslers are routinely used by doctors themselves to help diagnose mental illness. We can see that there was a change, but it wasn't huge. So we find that The purple line is mental health in 2018-19, and in 2020 that line was less steep. There was a drop in those who are kind of mentally more healthy, and a slight increase here in terms of worse mental health over time, and there wasn't much going on in terms of probable serious mental illness. So again, these, are probably mild stress, anxiety, short-term issues which are reflected in this score. But again, we don't know how that has gone on. And again, this is just doctors. We haven't looked at nurses or the health professionals who are at the front line of this, as many of these issues will continue. And as well, one of the key things is supply chains of resources to hospitals. Personal protective equipment has been a big issue, and it still is, I think, in many places. I don't think this has actually gone away or been properly solved. But nevertheless, that has been a big issue that you'd think with pandemic planning that would have been set up for this, but clearly not. And that left a lot of doctors and their own families personally at risk of infection. So this is a huge issue, and we know there's been a lot more research on what works and what doesn't work now, but I think there's still a lot to do here. So just to conclude, I think overall there has been a huge impact on demand. Some of that is short term, some of that is longer term. We don't know quite what's going to stick. But it's that change in demand and use of healthcare and how people use healthcare and the kind of people who use healthcare that's really had an impact on the health workforce. Hospitals and practices had to pretty much overnight change what they do, change how they make appointments, change how they interact with people, supported by telehealth, and other models of care. But again, that has caused a lot of things to change. Overall, I think COVID has accelerated pre-existing trends in virtual medical care, where there's strong support for this to continue amongst patients and health professionals, but there are also some quality concerns. There's a growing lack of affordability, continued falling growth in the use of private medical care. That was happening before COVID. That's likely to have accelerated. And I think overall, we do need to think about how to use the pandemic to redesign healthcare into the future. How do we adapt to this demand volatility that we're going to get as we continue to get COVID spikes until an effective vaccine is available, plus the issue of uncertainty about future pandemics? What's the role of fee-for-service and public-private funding models? Because that's been an issue where the government, in order to get extra capacity, has had to give a large sum of money to the private sector in order to generate capacity. Is that the right way to go? How can we better integrate public and private sectors and also aged care and some of the strange incentives that our healthcare system have really been brought to the fore and have often, prevented effective care from happening. And also, generally then, we do need to look at new opportunities to improve efficiency and improve health outcomes for patients. I'll stop there. Thank you, Jeffrey.
Tony, thank you very much indeed. That was fantastic. It was a tour de force, really, right across many issues that we're concerned about. I heard stuff about people and their capacity to pay, how the health system is coping, utilization of services, which dropped and is now bouncing back, clinicians' well-being. It was fantastic. There's at least one incoming question that you'll have to deal with shortly, Tony. I'll just put you on alert. And one is the question that I think struck me was whether there's a differential across the states and territories on some of this data, and in fact, even whether you've gathered that data or are you staying at the pan-Australia? I'll let you reflect on that, Tony, and on behalf of the whole of the webinar, thank you very much for preparing such an excellent presentation. Next speaker is really emblematic about something, and that is, as a researcher, and in fact, as somebody who has a career, it's wise to choose wisely what you do for your career. Liam Caffery has been dealing with telemedicine way before the pandemic ever threw it into the spotlight. So however smart you are, Liam, you're way ahead of the rest of us, choosing a topic that in 2020 was going to become super important as a researcher. So Liam's a good colleague and friend of the Partnership Centre in Health System Sustainability. He's got a PhD in medicine. His research is centred on pragmatic trials of telehealth services. He's been doing this for a long time. He has a special interest in the use of telehealth for Indigenous health and for rural health delivery. He's involved in telehealth service development, delivery and evaluation across a broad range of telehealth services, and he uses implementation research and implementation science ideas and principles to understand why telehealth, teleconsultation, why these sort of services work in some scenarios and not others. Liam, welcome. Thanks very much for being a member of the PCHSS and preparing your talk. Over to you.
Well, thanks very much, Jeffrey, and thank you for the invitation, the opportunity to speak here. So telehealth's been around for a long time, but generally it hasn't been widely practiced in Australia. Now, that was before COVID. So the result of COVID saw an exponential increase in the use of telehealth, and this was driven by a need to reduce viral exposure for both patients and clinicians, while still being able to provide healthcare services. And the introduction of MBS subsidies was a major driver in making this happen. So in this presentation, I want to focus on one discipline, namely general practitioners. GP consultations use around 80% of the MBS telehealth subsidies, so they're a fairly big player in this context. I want to initially explore telehealth for GPs in two time periods, before and during COVID. And generally speaking, COVID was the first time that many GPs practiced telehealth and many consumers used telehealth for the first time. So COVID will give us the opportunity for healthcare reform. Some learnings from this period will inform the benefit of trying to sustain telehealth, both for pandemic preparedness and to ensure it adds value to everyday healthcare delivery. So if we start with the pre-pandemic period, in 2011, MBS item numbers for specialist video consultations were added to the Medicare benefit schedule. In conjunction with these, there was MBS item numbers available for general practitioners, practice nurses, optometrists, Aboriginal health workers who would accompany the patient or be at the patient end as a support person for those specialist video consultations. So pre-pandemic, their major role of GPs was a patient end support person. There were geographical constraints to these specialist video consultations, and that they were only available for people that lived outside of remoteness area 1. That is, they lived outside of a major city, which meant that they serviced about 32% of the Australian population. And we know that GPs attended around 50% of specialist video consultations. Now, that figure hasn't changed since the introduction in 2011 right up until now. More recently, there were a very small number of MBS item numbers available for mental health conditions that are available for GPs. We can see from this graph here, if we look at 2019, the purple bar is general practitioners. So we can see the uptake of these direct to patient consultation MBS item numbers. There's very, very, very small uptake. We prepared a report for the Health System Sustainability Centre called the State of Play of Telehealth in Australia. We identified a number of commercial providers of GP telehealth services. In fact, we identified about 17 that were operating in Australia. And most of these looked at providing very simple interactions or transactions with the healthcare, such things as medical certificates, prescription repeats, referral letters, that type of thing. And in fact, 2 out of those 17 commercial providers were medical certificate only services. Their only offering was to provide medical services. Now, these commercial providers were presumably viable because they continue to operate, and they were funded by a complete out-of-pocket payment from the patient. And they relied on a convenience premium. So if you didn't want to have to take a couple of hours off work and go see your GP and sit in the practice and to get a repeat prescription. So what could be, you know, less than a 5-minute interaction with your GP, then you may be willing to pay. And similarly, if, for example, a parent with sick children who didn't want to take, you know, siblings to the GP surgery may be willing to pay for these services. And there's also a very small number of other government-funded services, such as Health Direct, which did offer some after-hours GP telehealth after nurse triage. So fast forward to COVID. So early this year, there was a substantial number of MBS item numbers added to the Medicare benefit schedule for GP to patient consultations. Now, these commenced in March 2020, and they were available for 6 months initially, and that has recently been extended a further 6 months. So they're available now until March 2021. Now, some things to note that were different from the specialist offerings is that there were no geographical constraints, meaning that every Australian had access to MBS subsidised telehealth consultations from their GP. You could do this via telephone or video, which was a real change in the current offerings. And there was equivalent reimbursement whether the consultation was done in person, via video, or via telephone. MBS published a number of guidelines for these, and I think it's worth noting that video conferencing was the preferred approach for telehealth. However, there was allowance for these consultations to be done in audio only, i.e. telephone, under the stipulation that if video was not available. So I'll just highlight that guideline. So we've been tracking the use of these newly introduced temporary MBS item numbers here. So I'll draw your attention to this graph here. Unfortunately, the MBS website's no longer available, so I can't provide the July data. But if we look at the grey bars are telephone consultations and the red bars are video consultations. So we can see straight away that there's a substantial number of telephone increases and a very, very small increase in the number of video consultations. Now, the purple line, that's the number of in-person consultations. So in-person is still the predominant form of consultation via GPs that are funded by MBS. And notably, during the COVID period, April, May, June, there we had, you know, over 3.5 million telehealth consultations and 11 million in-person consultations. So the number of MBS subsidised consultations actually increased during this period. Just to look at that graphically, if we take a snapshot of May, there was around 12 million MBS funded GP consultations. 3.8 million of these were done via telehealth, and of those, 3.7 million were telephone, and only a very, very small number of video consultations. Now, you won't see the detail in this slide here, but I just want to compare video and telephone with other discipline groups. As I've said, the grey bars are telephone, the red bars are video. So if we look for those mental health, the two graphs at the bottom of this slide here, psychiatrists and mental health, you see that a substantial amount of their telehealth is done via video, which is not what we're seeing with GPs. And this may be because mental health and psychiatric consultations rely on that non-verbal communication. Non-verbal communication is said under a number of models to be about 50 or 55% of all communication. Specialist, not a huge percent, allied health, not a huge percent, but it's certainly a lot more than GPs. So again, examining why GPs don't want to use video is probably worth looking at. And there's been a lot of forum comments and surveys and commentators try and explain this. I think there's little doubt that telephone is simpler and easier and requires no technology investment in comparison to video. GPs have always used phone, but it's now that there's an MBS item number attached to it that activity is reported. One survey said 61% of GP respondents said it was the technical ability of their patients that was a barrier to using video consultations. Others report that they've got 10 minutes for an appointment and they don't want to spend 2 or 3 minutes dealing with the technology with the patient. So that was another barrier. And others claim that patients want to use the telephone. Now, this is true, and we've certainly heard a number of stories about how patients don't want to be kept at home, or those non-Victorian patients don't want to be kept at home, and that they can go about their activities of daily living, and you go to Bunnings or go to coffee and then just have a telephone consult rather than a video, much more convenient for patients. So that was also another driver. Now, I think these next two slides, I think, sum up the majority of reasons as why telephone is used far more than video. We've got one very honest GP that said that at least some of these consultations relate to GPs taking advantage of the Medicare benefits for service that they had previously provided for free. He said, I'm guilty. I used to send patients a report on their test results by SMS at no cost. Now I found them, discuss them, claim a bulk bill, MBS item number. Doesn't cost the patient anything, which I think is an important consideration, but it's $38.75 to the government. And the other one is, about change management. And this commentator says the phone call as a form of telehealth has been embedded in traditional GP practices since the phone was invented. And we know when it's appropriate to use the phone for patient care, and we know the limitations of phone consultations. So they're very comfortable using it for both clinical and medico-legal reasons. So the opposite of this is that video is a relatively new paradigm in patient-doctor communication in Australia. And like any new paradigm, there's uncertainty and uneasiness about how it works. But they note that this will evolve with experience. And this is consistent with international studies. I refer on screen there to a study done by Trish Greenhalgh, who looked at video outpatient consultations in the UK. And this study identified that there was rather a steep learning curve when clinicians initially started using video consultations, but that resolved over time and with their experience with the modality. One of the things we should note is that telehealth cannot substitute for every interaction in the healthcare system. And there's certainly things that require direct examination or direct physical examination or are procedural in nature that can't be done by telehealth. What we do know is that people are learning to use video a lot more for indirect examination. And these are the things that a number of GPs feel that this can be done. But such things as, say, pulse rate, where, normally the GP would, take the patient's wrist and take their pulse rate, but they can get the patient to actually put their hand on their carotid and tap the table in time. So they've learned a new way of gathering information. And video or telehealth does require that. Doing a neurological assessment can be done via video, but is substantially different to the way that you'd actually do that in practice. And, as previously noted, the telephone can be used quite effectively for a number of interactions, but they tend to be simpler interactions. So I think one of the things that we've identified during this period of COVID and the use of telehealth, or the rapid uptake of telehealth, is that our current workforce has a deficiency in skills in video. As I've alluded to, there are different ways of gathering information that need to be done in video to what they've been practicing potentially for years or what they were trained to do at university. So we currently have a deficit in those skills in using video consultations. And a lot of people haven't recognized the fact that it's just not flipping a switch. You do need to learn these skills. So there's no doubt that one of the things for future use or sustained use of telehealth, we need targeted education and training. Both at the undergraduate and postgraduate levels. A number of strategies is, where possible, provide ongoing technical support and training. And I do recognise that this is not feasible in small to medium-sized GP practices. Consider professional association accreditation. Have continually updated guidelines from the professional association, those that identify which patients are amenable to telehealth and how examinations can be done in those ones. And one of the obvious things is to build telehealth into university curricula or other training such as RACGP training. So these thoughts are expanded a little bit more in the article that I've got there about sustaining telehealth beyond COVID. Now, of course, the use of telephone has raised a number of questions and concerns. The first is the quality of care of telephone versus video, the cost implications, whether we are simply supporting low value care, and whether it is sustainable beyond COVID. I'll draw your attention to this systematic review, and the findings from this review was that video was better at reducing healthcare utilisation than telephone. So people that had a telephone consultation often had a subsequent very close time period for an in-person or another video consultation. Video takes longer than telephone. And again, I draw your attention to this because in Australia, MBS time tiers reimbursement. The longer the consultation, the more reimbursement. So that I'll just emphasise that point. Outcomes important to the provider were more superior with video. They made fewer medication errors with video. There's greater diagnostic accuracy with video and improved decision-making accuracy. So there is a wealth of evidence to support that video is likely to be a superior consultation technique in comparison to phone. So I just want to compare activity. So if we compare the same month, 2019 to 2020, and what we've seen is that we've had an increase of, in March, $1 million at a cost of 25 million, 2.5 or 2.3 million extra consultations in April at a cost to MBS of 56 million. May's an anomaly, and that's related to May 2019, 14 million consultations for the month, which is substantially more than the running average there in June. So what we need to do is we need to consider these over a longer period of time to see the effect of the cost. The other thing, as Tony talked about in his presentation, people are deferring healthcare treatment. So until that normalises back to the amount of healthcare that people would do, we need to continue to look at the trend, to look at the impact. We've recently published this review here about health system costs. And what was somewhat of an unexpected finding is that telehealth does increase the cost from the perspective of the healthcare provider in many scenarios. So our conclusions were health services considering implementing telehealth should be motivated by benefits other than cost reduction. So if we want to sustain telehealth, are we willing to absorb these additional costs or support these extra costs, given that they were likely to provide patient benefits and increase productivity? That's another consideration. And I know this is slightly out of context, but this is a study that we did of telehealth activity within the Queensland State Health Department. And we basically calculated for 70,000 odd appointments, how far a person would have to travel and the amount of time that they needed to take, multiplied by the average salary. And we found for these 70,000 consultations, there was about $9 million in productivity savings from people not having to take time off work. Again, the scenario is slightly different in that it was a small number of patients travelling large distances, but for GP consultations, and particularly those provided into metropolitan areas, you've got the opportunity of having a very large number of consultations, albeit patients taking a small amount of time off. So the economics, I feel, is likely to give a very good societal and cost benefit if we consider that. Now, everyone's looking at reforming the health system, and funding reform is an important part about sustainability of telehealth post-COVID. Some commentators are calling for a lower reimbursement for telephone based on the fact that a simple transaction is likely to take less time. This is being, some lobby groups are arguing against that. Other commentators are calling for a cap on the proportion of telephone consultations that a GP is allowed to do, meaning that when they do use them, and most people recognise that telephone consultations are completely appropriate for a number of interactions, that they're used appropriately rather than using them less effectively, which is likely to result in a subsequent in-person or video consultation happening. We want a funding system that provides disincentives for misuse. So if you've got a funding system that overcompensates for low effort, then there will be then there's high risk of misuse. We've seen from those 17 commercial providers pre-COVID that they were aiming at very simple transactions, those 6 certificates and things like that. So there are services that will look at identifying that low-lying fruit. And as always, there are many proponents that look at broader funding reform and potentially using COVID and telehealth as a catalyst to achieve reform such as capitation or value-based payment. I will just note there has been already some funding reform in that to reduce risk. They've brought in, the health minister announced that to be eligible for GP funding, there had to be an existing relationship between the GP and the patient, i.e. there had to have been an appointment in the last year. But a lot of people thought it was rather short-sighted because it excluded from telehealth funding people that hadn't seen their GP in 12 months or people that used ad hoc services such as sexual or reproductive health where there wasn't necessarily an ongoing relationship. Just finishing up quickly there now, our whole concentration has been on synchronous telehealth, so video consultations and phone. It may be an opportunity cost that we don't look at using other modalities such as store and forward to address particularly some of those simple transactions. We've seen it very successfully used in the UK and the US where patient portals for asynchronous communication with their provider can be used to address those. So just a couple of concluding remarks. COVID brought about forced utilisation for the first time of telehealth. We identified that there's probably a deficit in workforce competency and skilled, particularly in video telehealth. And a lot of this reform will be driven by a funding model that promotes high value care, that disincentivises misuse, and that provides access where it wants. It doesn't discriminate against those patients that haven't seen their GP in the last year. But we should also have some other cost considerations rather than directly the cost to Medicare, such as the societal benefit and patient costs and experience. Thank you.
Thank you, Liam. That was beautiful. Another tour de force. I must say, thinking about both of those talks, the lovely diagrams and data that you've both produced, and Liam, in your case, the idea of phone versus teleconference, video, and face-to-face, and learning about the types of modes for what kind of service best works was really a highlight from me. And I think it was interesting also, both of you gave consideration to how care is delivered, by whom, and at what cost, with economic implications for both of you. Really, really good. We've got half a dozen questions. We won't deal with them at the moment. Just suffice to say that they're about, Tony, whether MABEL and the other data is differentiatable by the states and territories. We might respond to that one separately. Also about virtual care and different models beyond what you were saying, Liam. And both of you got accolades from some of the participants for the wonderful talks that you gave. So thank you very much. By way, and we'll come back to people with their questions. So just in closing, I think we've learned a lot today about COVID from different angles. I just applaud the studies that have been done. I always get amazed at how productive researchers are. And the fact is the first case was diagnosed on the 31st of December last year. And this is the quality of research that researchers that we're associated with in the PCHSS have come up with. It's awesome. Thank you very much indeed on behalf of the whole audience. And just in closing, I'd like to thank the people who contribute a lot to my own work and the studies I started out with at the top of the webinar. People like Louise Ellis, Stephen Tran, Chiara Pomare, Joanna Westbrook, and many others. Thank you. And also thanks especially to the PCHSS Observatory, Yvonne Zorinsky, Kaylin Smith, Alex Bedavoy, and other colleagues, Isabel and others. So thank you very much for all the work you do to support all of the work of the researchers. It's greatly appreciated. I'd like to close the meeting and thank everyone for participating. Thank you very much indeed.